So with our treatment, we have compensatory and rehabilitative, both generally being implemented at the same time. Compensatory strategies are our quick fixes. This is what we use to get a person eating safely or maintain them eating safely and efficiently. They're attempted during the instrumental examination so we can see what works, what doesn't work. They're manipulated by the clinician in that we decide, here's the sign that needs to be addressed, here's the appropriate compensation to employ. It's been suggested that most compensatory strategies require limited cognition. I agree with that, but we have to remember that our patients, our clients, are implementing these strategies over the course of a meal. So I would argue that compensation really requires more cognition, more comprehension if we want our patient to be able to do it independently. It's the rare case in which someone is always available for every meal to remind the person to implement a strategy such as a chin tuck. With compensation, benefits are immediate, not permanent. Again, the thought is once you eliminate that compensation, swallowing goes back to how it was. So if we're implementing chin tuck to prevent aspiration before onset of the pharyngeal swallow, the moment our patient returns his or her head back to neutral, aspiration will occur again. So to prevent it, the chin tuck has to be maintained for that specific consistency. Rehabilitation, on the other hand, alters physiology. It's not used during the course of the meal. This is something we do in our therapy sessions. So we're wanting to make a permanent change in swallowing physiology and have the patient get rid of that compensation. Compensations ideally are not to be lifelong strategies that are used by a patient. Rather, they're short-term strategies to improve safety and efficiency. We implement rehabilitation to get swallowing better and thus withdraw the need for compensation. Again, it's been suggested that rehabilitation requires good cognition. I agree with this, but we can rehabilitate our clients who may have reduced awareness, reduced memory, reduced attention, because remember, we're there with the patient as they're completing the exercise. Yes, if cognition or comprehension is reduced, we can't design a home program unless there's a family member there to help implement it. But for the most part, with most of our strategies, we're trying these or working on these as a person is in acute care or the rehab setting or LTAC. So we would be there to guide the patient.